Could you go back to the slide, the grid slide that you had there? Because there's a lot of really rich and useful information on that. And it leads to my first question for both of you. AJ, you are in a CMS model, but you could just as well have contracted with some other healthcare entity, a private sector payer, Medicaid, managed care organization, or provider. What do you both see as the advantages, disadvantages of working with either payers or those that are engaged in the delivery of healthcare? And you have some of the answers on the page, but some more color on that.
I think I'll speak to the bigger issue. And first, let me say that I do work for an area agency on aging, and applying for the accountable health communities was part of our strategy to work and contract with healthcare providers and payers, insurance companies, to deliver our services, because we're facing a demographic landslide. Our population in Colorado is aging quickly, and we're not getting enough funding from the federal and state governments to match the need. And so the biggest issue we face is the free rider problem. We go and talk to healthcare entities and hopefully soon health insurance companies, and they say, why would I pay you for that? You do it for free. And the reason you should pay us for that is we don't do it for free exclusively for you, and it's a scattershot approach. But you will get more results, better results, if you hire a community-based organization. And so overcoming that institutional struggle, but also, the first one up there, the time it takes to establish a contract. Your question about getting intimidated to talk to the healthcare C-suite, I started there in 2016. You quickly get past it, because there's something that I realized along the way, and that is we're the experts. We're the experts in community-based services, and we have the product that can contribute to lower healthcare costs. And yes, they have very nice cars, very nice offices, but they are experts in clinical services, and we are experts in community services, and that's what gets us through there. And we love. You have given me new hope. The two of you, you have warmed my hearts. But we will take grants, but we don't want them. We're an equal player, and we want your investment.
Marisa.
Yeah, so I think, the opportunity that exists with this improved integration is really about addressing a person's holistic health needs, right? Health happens in clinics and hospitals, but much more of it happens in homes and in communities, in a person's apartment where there might be, scatter rugs down on the floor that are a fall risk, among, the caregivers who are providing services, unpaid services to older adults and persons with disabilities who need supports, respite, and so forth. So there's a real opportunity here to address those needs. And, just to echo what AJ has been saying, if community-based organizations are helping to improve outcomes and potentially, depending on the payment model that's being used by the healthcare organization, to help generate some of the shared savings, then they should get a share of those savings. And whether that happens via, some kind of shared savings ACO model or some other way, there has to be, social service organizations can't bear the brunt of unfunded referrals for very long. So we've had payment reform in healthcare. We also need to see that stretch outside of healthcare organizations to include community-based organizations that are addressing health-related social needs.
That's very helpful. And as someone who comes from a payer, so I've been at CMS and now in a nonprofit commercial payer, I'm resisting the urge to respond directly. But my role here is to ask questions and probe.
We can talk later.
Yeah, absolutely. Let me ask the question in this way. I think tied up in this is the question of value. So the idea here, or the concept, is that we as a nation spend $3 trillion on healthcare. Most of that is in healthcare delivery. And so most of it is funded either through the public payment systems, so Medicare and Medicaid, or premium dollars that everyone in this room pays, either through employer-sponsored health insurance, through this Rube Goldberg tax system or directly through an exchange product or a fully insured product. And the idea is that by accessing some of this vast pool of funding to fund things that we all believe, I suspect if we're in this room, to be morally right and important for people in the United States, that we can produce some value and reduce total cost of care. Mm-hmm. How would you communicate that value? Because ultimately that has to, in order to access this pool of funding, you have to get through an actuary, whether it's the CMS actuary or the actuary in a commercial payer organization. How would you communicate that value?
Well, I think in time the data will be there. However, on a grand scale, you're never going to get a control group. It's just not going to happen because nobody's going to say, "Oh, you're hungry. That's nice." We're going to say, "Let's get you some food." But I think you can look at the results that we've seen already. Lower emergency department visits. Mm-hmm. As a healthcare payer, why would you not invest in that? Better outcomes. We did a pilot with an ACO, and our community case management went into houses. And the ACO was laughing at us. They said, "We're going to give you these 50 patients. If you get into 5, that's a success." Well, we got into 55. They gave us more. Mm-hmm. And this was our case managers with institutional knowledge and years of experience knocking on doors and saying, "Hey, I'm here to help." And those people had better outcomes. We got to them too late in their medical situation. But a perfect example, our case manager walked into a house and asked a woman, "Do you take your medication?" And she said, "Yes." And she opened a drawer and she... range of pills, not pill bottles, mind you, but pills came rolling forward. Mm-hmm. And she picked one out and said, "Oh, I haven't taken this one today," and threw it back. My Lord. But yes, the outcomes are there on the individual level. And if you look at your plans and work with your area agencies on aging or other community organizations, you will be able to pick out details of success. And it's just a matter of scaling it.
Mm-hmm. And we spend a lot of time at the Aging and Disability Business Institute talking with community-based organizations about how you present that value proposition to different kinds of healthcare organizations. And part of it is the data that AJ was talking about, which is slowly coming, both from the existing contracting as well as other kinds of research studies. But part of it is also the stories, that AJ just told, that we heard on the panel before, and so forth, that about what the power of being in the home and in people's communities can give. And that's the sweet spot of community-based organizations, right? They're the eyes and ears in the home, oftentimes. So I think that is part of it, but part of it is also about the sweet spot, matching what community-based organizations are good at with the sort of the needs or the pain points of a particular payer and the members or the patients or the individuals, however they term it, whom they serve. And finding that matchup of the services that a particular healthcare organization's population that they serve needs with what a community-based organization or groups of community-based organizations, because often they have a lot of different needs, can provide.
That's really helpful. Let me rephrase my question and ask it in a slightly more pointed way. Mm-hmm. I have no access to information at CMS anymore, so this is pure hypothetical. But what I fear is that the evaluation of the Accountable Health Communities model will show a null result. Maybe because the period of analysis is too short, maybe because we're not looking at the right things, maybe because it's really hard, and most CMMI models actually fail. What is the path forward after that? How would you interpret and communicate that? And
sorry, I'm excited to answer this question because you're right. And I will tell you right now, if you're in a health system or an insurance plan, referrals are as close to useless as you can get. Mm-hmm. Just because you've identified a need and sent a referral, so what? You haven't built a relationship with that patient or client, and they will not access that service. Dr. Gottlieb brought up earlier that a remarkably small amount of people actually utilize the community-based service. There's a lot of reasons for that, none of which is they don't want it. In terms of they may not want a meal on wheel, but they want food. It's how you ask the question. It's how you send the referral. It's the relationship you have with the community provider. But you're right. If they analyze referrals, there's going to be a null result. And so I would strongly encourage everyone to look at the people who completed the referral and who actually got the service. There will be a result there. But also one thing we know is that the people that generally use AAA services they start around 75 years of age, and they're well into the course of medical treatment. They are going to utilize resources more than others. But if you can find the cohort, and I can't tell you where it is, just before that and provide them assistance and them services, then you will see the result. So I think you hit the nail on the head. Time is the key piece here. 2022 is not going to get it done for the AHC. But over time, you will see a stronger result with acute investments in community-based organizations to address health-related social needs, and then longer-term investments to address the social determinants of health.
And I would just add, our hope, given the sort of the issue with not funding the social services that can address those, the sort of list of social determinants of health that are, sort of targeted by this program, is that what it's going to point to are these gaps where services are and aren't, and where payment sort of fails in terms of this, so that we can identify, more opportunities to be able to align different funding sources to look at where those can come together in order to address that a person's holistic health needs.
I want to turn to the audience and take questions that you may have. There are microphones on both sides. Yes, please tell us your name and your organization.
Buenos días, Lourdes Rodriguez with the Dell Medical School at the University of Texas in Austin, and a roundtable member. So the problem of metrics for me, it's about trying to take a temperature with a ruler. You're just have the wrong instrument, and you're never going to find the right answer. But that's not my question. My question is about the comment that you made about contracting through networks. Mm-hmm. So that's, to me, evokes Hunger Games. And this this competition for uniformity, and there's a winner, and we're corporatizing the provision of social service needs, so that there's going to be a survival of the fittest. How do you grapple with the need for a deep knowledge of the communities that we're serving, with the uniformity of one single contracting? Is the network allowing for that diversity within the group? Thank you.
So the Older Americans Act, which funds the area agencies on aging, requires that we work with people 60 and over. But that's one regulation. We can work with people younger, and we do with other programs. The area agencies on aging are the hub of a network that already exists, and it's been in existence. In Denver, we've been the AAA since 1974. It's not really a Hunger Games theory, because we both provide services and contract for them. So we could receive a contract, or we will receive a contract from a healthcare payer provider, and then we would provide some services, but they would be contracted out through our normal channels, which we already have in effect. We issue RFPs every 2 years. Dr. Cog, where I work, the Denver Regional Council of Governments, I think last year we funded $14 million into the community through these contracts to deliver Meals on Wheels, transportation, some legal services, chore services, which are some of the more important. And so that there's not going to be a winnowing effect, because those dollars will go farther. And the networks already exist. So there's 0 to 5 with WIC. There's 6 to 59, you're on your own. And then there's 60 and over with the Older Americans Act.
So I would just add, you bring up a really good point about sort of this corporatization, and I think one of the concerns that, we've seen a lot of concerns. We have with this, not necessarily in network building, but that social community-based services or social services will get over-medicalized when these contracts happen between community-based organizations and healthcare organizations. So that tension is there. Nobody got into social services. I have a master's in gerontology. nobody I've ever encountered in the field said, oh, I got into aging because that's where the money is. So I think, it's really balancing that tension of being sort of mission driven with being data informed and the need to generate revenues to be able to, number one, stay afloat, and number two, to be able to innovate and better serve and expand the populations that an organization serves. The networks that we've seen vary depending on the community or the state in which they are. They include a lot of different kinds of partners. And in my view, from having done this now for several years with community-based organizations, both in the federal government and now outside for a nonprofit association, is that the networks tend to err on the side of inclusivity rather than exclusivity, because they're trying to meet the needs of their community as well as the needs of the healthcare organizations with whom they're contracting and the members or patients whom those organizations serve.
Thank you.
Mm-hmm.
Hi, I'm Bob Kaplan from Stanford University. One of the issues that has recurred through the morning, and it's just been bothering me as I've been thinking about this. Raul mentioned that a lot of money flows into the pockets. It sort of flows out of the pockets of payers into the pockets of provider groups and hospitals and so forth. And a couple years ago, that was $3.2 trillion, and I'm sure it's much higher now. And that maybe a third of that, depending on the analysis that you look at, is for services that don't make much difference. And we have this idea that, well, we'll just figure this out and some of that money will flow differently. And if people just have enough information that it will move out of pockets and into pockets differently. But I just don't see much evidence that that's happening. And part of that is because that hospitals and provider groups are happy with the current situation, as far as I can tell. And actually insurers are happy with it. They have their medical loss ratios and everything seems to be working for them. So I'm just curious, how do we address this?
Well, you're right. With all the great work that's going on, asking healthcare to invest in something, separating healthcare from money is really hard. It's just really hard. They don't share very well. I could be more blunt, but my boss is here. There needs to be regulatory change. There needs to be incentives provided, not just in the MLR, not just in quality measures and the satisfaction scores, but there needs to be regulatory change. And there needs to be a realization that healthcare is one subset of care. So I should say clinical care is one subset of healthcare. Community care is the second, and public health is the third. It's one piece of the pie. And there needs to be that understanding at the regulatory and in legislatures. And somebody has to basically say, this is how it has to be. Because honestly, this is how it has to be. We're about to spend, in 7 years, we're going to have to spend $2 trillion on Medicare and Medicaid combined. And that's at the federal level. Each state is drowning is going to be drowning in Medicaid payments. In Colorado, we're going to be able to pay for education and healthcare, and that's it. So there has to be something to be done. And I do think it has to happen at both the state and federal levels, but also there has to be a realization at the insurance companies that they're paying for the most expensive type of care, and they're expecting cheaper prices. That doesn't make sense. There's a disconnect there that needs to be fixed.
And let me add a hopeful note here, because while we haven't seen a lot of change, we have seen the conversation change a lot over the past several years. And what gives me hope right now is what we're seeing happening within Medicare. The addition of the new special supplemental benefits for the chronically ill under Medicare Advantage, while there aren't additional dollars necessarily attached to it, where Medicare goes, other payers tend to follow. So if we start to see some results out of that and potentially some savings within the Medicare Advantage space based on the provision of these benefits, if we can do that right, fingers crossed, I think we're already starting to hear the glimmers of conversations about, well, can we take what we're doing with Medicare Advantage and also look at Medicare fee-for-service? So I think we're on the cusp of something in terms of some of these changes and hopefully seeing some of this happen in the future.
Hello, I'm Jayla Sanchez-Warren. I'm the director of the Denver Regional Council of Governments Area Agency on Aging and AJ's boss.
Hey, boss.
We have a lot of fun. I don't have really a question. I have more of a comment. AJ found this grant, and he asked me to read it, and I was on my way to Washington. I read it in the airplane, and I said, it was a page turner for me. I was making notes in the margins. Oh my God, this is perfect. This is exactly what area agencies on aging, we need to get in this space. And then I got a call from ACL, and they said, we don't advise it. And my boss said, no, I don't want you to do it. And I said, we have to. We have got to get into this space. And the reason was because the grant doesn't, or the demonstration project doesn't allow you to pay for services, right? And I thought, well, we're just going to try. And I didn't think we'd get it. And I'll deal with that if we get it. And we got it. Uh-oh, now what, right? So I got a grant from another organization to partner with this grant to provide services. Because we already have waiting lists. We have waiting lists for Meals on Wheels. We have waiting lists for transportation. We have waiting lists for in-home services, for grandparents raising grandchildren, all sorts of things. So how was I going to add this new population on, right? What I need to, everybody needs to hear this, please. Referrals don't change health outcomes. Services change health outcomes. And what we're finding, one of the most challenging parts of this grant is actually getting people, once we identify them in the clinical settings and we make those referrals, we have a customized referral list for them and phone numbers and actual people to call, they don't do it. And a lot of times it's because they got too much else going on. My mom's currently going through cancer treatment right now, and she has a list of all these things on her refrigerator, cards and little flyers and she's going to go do that when she feels better, when she has the energy. See, the people that we're working with have so much stuff going on in their life that they don't want to go out and fill out a SNAP application because it's 22 pages long. And they don't want to be asked all these questions. My mom goes to the doctor. She has 4 or 3 appointments in one trip. She is exhausted by the end of the day. She doesn't want to go to the grocery store to get food. She doesn't want to go to a restaurant. She wants to go home and go to bed. But she needs that nutrition because she didn't eat, because she had to have her blood done, right? All of those things. We have got to meet people where they're at and understand what's going on, and then get the services they need when they need them. We can't wait for Meals on Wheels for a month. We need to get them 24 hours after they get out of the hospital. That's the key. The area agencies on aging have been doing this nationwide. We cover every inch of this country and our territories. We've been doing it for 45 years plus. We know how to do this. Partner with this organizations, this network that already exists. Don't invest in creating another one.
So I thank you for your comments and for your work. I think we have time for just one more question, and I will give it to John.
Sure, thanks. John Auerbach, Trust for America's Health. You know, when I was at CDC when the accountable health communities were being developed, and given that they included in Tier 3 the coordination and the joint planning, I think some of the expectation was that the screening of patients would identify the need, and the healthcare institution would bring a lot of people to the table to do the planning, but that the planning wouldn't simply be about what services could reasonably be paid for by healthcare as beneficial to changing the bottom line by thinking outside of the sort of narrow clinical box. But it was also, would that allow a sort of population-wide aggregation of data that would say, here's the need, here's the gap, and what are the policy-related strategies or other funding-related strategies not coming from the lead medical organization? In some instances, like affordable housing, wasn't going to be realistic that if affordable housing was found out to be a major gap, that the healthcare facilities were going to pay for affordable housing for every patient. So I guess the question is, has that happened? Have these discussions taking place also looked at what needs to be solved outside of the contracting process, but by bringing policymakers to the table, making the case that broader policy needs to be changed, funding for through whole other sectors in order to make sure that there's adequate resources. Have those discussions occurred as well?
Everybody I talked to in Washington worked on the AHC before I did. It's amazing. Now I understand the gap analysis and its genesis. I understand it, but you're right. The big issue we face is the intersectionality of needs. Nobody wakes up one day and is food insecure. It happens over time. Nobody just has, well, a lot of people have one need, but usually people have 2 to 3. And now you have to navigate 2 to 3, addressing 2 to 3 needs. And so let's say it's food and transportation and utilities, the 3 easy ones. So you have, if you absolutely have no food, you can get an emergency SNAP application. It takes a week. So that's not good. But then you got to go around to different food banks. They don't advertise. We did an analysis and found that of these 69 or 64 food banks in our region, they had 49 distinct operating hours. So you have to navigate that. Then you have to apply for utilities when you're hungry and worried about your kids. And then you have to apply for transportation. Now, we have to talk to you, and we don't have to. We talk to you because you're the expert in your own life. What's the most important thing to you? And it's actually getting my kid to school on time with food in their stomach. So, okay, food. Let's do food first. And then that takes a while. And then utilities takes a while. And then all of a sudden you're sick. And so it's the intersectionality of the needs because they don't exist in a vacuum. And I do understand where the hesitancy for CMS to pay for community-based services came from. It is a barrier that we can overcome. But as I said before, no one's going to step up to pay for a system they think is working okay. And there needs to be an education on the lack of investment in the social services in this country. And now that the realization that the value is there needs to be investment. I think it's wonderful that Kaiser built housing in Oakland. I don't think it's a good idea that Kaiser build housing. I think they should be making investments in housing. I think they should realize the value of housing and the value of food and make investments. But turning healthcare providers into construction workers and grocers is the quickest way I know to explode the cost of housing and groceries.
Anything that you would add?
No, because I think John's question is really about sort of what is what you were talking about with Tier 3 actually happening now in communities. And I think, I think AJ has the best experience with which to answer that question.
Yeah. Please join me in thanking AJ and Marisa.